Yeah, thanks, Pete. I mean, this is a great topic for discussion, and we're going to ramp it up a little bit more now with intra-articular distal femoral fractures, but now with some bone loss and how do we manage it? I think it's important to remember that these are often really complex fracture patterns in young patients, often due to high energy injuries. They're often open, and they're often in multiply injured patients. So you have to consider your timing of surgery, your rehabilitation. So the question about weight bearing, for example, in the younger patient, often then, if they've got both limbs injured and an upper limb injury, then actually limiting their weight bearing on their leg may not be particularly helpful. So you may want to think about weight bearing for that reason as well. So I thought the best way would be to illustrate with a couple of cases, because these are difficult fractures to find much evidence or literature about. So the first case is a 51-year-old chap, motorbike versus car. He has an open right distal femoral fracture, which you can see here in the photo. Also has a closed right pilon fracture, a left knee dislocation, a left intra-articular distal radial fracture, and a right ulnar shaft fracture. So the question here is obviously timing of surgery, finding the appropriate surgeon for the different parts of the body, and then thinking about the patient's rehab and their post-operative course. But with regards to this intra-articular right distal femoral fracture, you can see here from the radiographs, and as Jane pointed out earlier, often CT scans aren't particularly helpful because it's just very bad. And my first consideration is, what's my surgical approach going to be with these? And I often pick an approach that enables you to adequately visualize a joint and also plan for any further surgery in the future. So often it's an anterior approach with these cases. And you can see from the photo there. And then the first thing is adequate debridement. So any loose fragments, devitalized fragments, non-critical parts of the convolution can be discarded, obviously not the condyles. And then once you've done a thorough debridement, it's then a case of reconstructing the joint. And they're using the techniques that Greg's explained, by headless compression screws for any Hoffer fragments. And then the difficulty is trying to realign the condyles. And as pointed out earlier, sometimes if there's trochlear bone loss, getting your condyles not over reduced is tricky. Maintaining the width of your condyles is important. So you really sometimes have to make a call on the table as to where you think the reduction is. And then I hold that with a clamp and then put some position screws to hold the condyles together. Having done that, and then thinking about the bone loss at the metaphyseal diaphyseal region, and what I'll then do is span the bone loss with a retrograde femoral nail, often using the diathermy wire as a kind of guide for your alignment, which can help. And then once the nails are across, I then often use cement as my sort of structural support for the bone void. It acts as a useful void filler as well. And then it also serves as your first stage for your emasculate technique. So then that means coming back and doing bone grafting as a second stage. So that's my normal go-to for these types of injuries. And that's the condyles reconstructed and the bone loss taken care of. And the great thing about this is that you can then close it and then you can get the patient walking, rehabilitating. I do fully weight bear. So this patient was fully weight bearing straight away. And then once they've recovered from all their other injuries and fractures, you can then think about your bone loss and how you're going to manage it. So in this case, you can see from the photo on the left, I've done a lateral approach for my second stage masculate, and I've used bone graft. Unfortunately, as you can see from the radiographs on the right, the masculate hasn't worked and the bone grafting hasn't incorporated and consolidated. With this particular case, at the initial operation, I'd shortened him 2 centimeters. So what I decided to do for the bone loss in this scenario was to lengthen him with a retrograde lengthening nail. So I pre-distracted it to the lengthening nail, inserted it as a retrograde nail, and then lengthened my non-union by 2 centimeters. And that's brought him out to equal leg lengths. And then I've done an osteotomy above the lengthening nail, dual plated, again, to allow weight bearing straight away, and then turn the magnets around on the handheld device, and now doing bone transport by dragging the femur back down to the condyles, and his weight bearings throughout this throughout the whole bone transport stage. And this is his overall journey. It's a 4-year process, but you can see with the final radiographs, he's got good regenerate, which is consolidated. His docking site has united, and he didn't need any docking site procedures. And you can see him rehabilitated and walking quite nicely there. So I think this technique in these difficult cases allows for, it's still a long process for the patient, but allows them to rehabilitate and return to work much sooner. So a second similar case, just to illustrate a similar sort of theme. This was a code red patient with open bilateral intra-articular distal femoral fractures, as well as a closed right tibial fracture, a closed right Montague elbow fracture dislocation, an intra-articular fracture of the other elbow, as well as a first metatarsal fracture. The left distal femur is the worst one. And you can see here from the CT slices, again, it has a Hoffer fragment. The fracture fragments are flipped, and it's multi-fragmentary in the metaphyseal diaphyseal region, as well as being open. So a similar sort of technique, open midline approach, restore the condyles, fix the condyles back to each other, and then a retrograde femoral nail with a cement spacer for structural stability. You can see here I'm slightly malaligned. That's mainly due to the severe lack of bone in the distal femur. But again, for the early stages of this patient's recovery, it allows them to start rehabilitating their knee quite quickly. And then with this case, what I've decided to do is a slightly different technique, mainly because of the poor masculine technique on the last case. So I've used a bone transport nail as my second stage for this bone loss. So this is an antegrade bone transport nail. I've used a lateral femoral locking plate to correct my alignment and also to give me some extra stability, because again, you can see from those intraoperative x-rays how little distal femur there is. Having inserted the nail, you then do a corticotomy above the transporting segment. And then I've used synthetic bone graft in the distal fragment just to help with my docking site union when it comes down to dock. And this is her progression. So you can see the radiograph showing the bone transport distally with regenerate forming at the top, which goes on to consolidate quite nicely. And again, her final radiographs and her weight bearing. I think this technique actually is a slightly quicker process because it's allows for the bone transport all in one and mitigates the requirement for mascule for such a long segment. And these are sort of the two go-to techniques I would personally pick for distal femurs with bone loss. So in summary, I think it's really important to recognize these are complex fractures with complex fracture patterns. You need a good visualization of the joint. You need to consider the whole patient in your management and their whole rehab due to the other fractures that they often have at the same time. And I think using modern internal fixation techniques, it allows for us to rehabilitate and return to early function. Back to you, Pete.
Cheers, Enis. That was lovely. I guess the first thing that jumps into my head in terms of an obvious question is, how do you have any advice to your colleagues on how to temporize these injuries? So let's take that first one you said. Massive, condyles are like this. Maybe there's a bit of Hoffer as well going on, and there's extensive metaphyseal comminution. And your colleague rings you up and says, Enis, what do you want me to do with this? What's your answer? How do I temporize this situation?
So I think in the first stage is an external fixator, just to hold the bone out to length. So that first case, I don't know if you noticed, there were some skin clips.
Okay.
So that had actually been debrided already. So that was the post first debridement.
Understood. Yeah.
So that had been poorly managed at the first stage. I think either way, so as long as there's some length and early debridement, then that's fine, and then we can then manage that once they've got over their code red and they've physiologically then been restored. So I think in the early stage, debridement, temporary stabilization, And then
And do you ask your colleagues to put blocks of cement in with antibiotic laden cement or anything like that?
So my
Keep it simple.
My preference would be to keep it simple. I think some form of void filler is useful to prevent that hematoma and environment for bacterial growth. So they can put a temporary cement block in just as an initial stage.
Yeah.
Yeah, but I think it depends on how well they think they're going to do their debridement.
Yeah. A question from the Q&A was, is there ever a scenario where you might bone graft someone acutely?
So personally, no. I think as well as everything else, it's then too much to consider. I think until you've got a stable soft tissue environment, and until you've got control of your sort of fracture, I think bone grafting acutely is difficult. I mean, one could talk about sort of free fibulas or sort of free bone transfers. Again, I think with the soft tissue environment, I think that would be difficult ask in that sort of first stage. I think this sort of technique allows weight bearing, gets them through that first stage, and then you can consider the bone grafting as a secondary procedure.
Yep. Jane, are you guys doing mascale up in Coventry? What's your go-to for restoring bone? Are you having a go at mascale?
I think I've come full circle. Like I've certainly had a few cases like Enis's, when we tried mascale to start with, and have absolutely failed spectacularly, if I'm honest. And they've ended up with distal femurs, which is also not the answer either. So my own views about mascale are that if it's a contained defect, so you've got one posterior cortex, and certainly for the distal tibial metaphysis, it sometimes can work okay. But for the distal femur, when it's a full segmental defect, I think mascale alone, without like Enis's technique of doing a transport nail, probably isn't sufficient. I find problems with the docking site always, so I think using the transport nail is a brilliant idea, which sort of has led us now to, is all that bone that you've just thrown in the bin, is do we need to do that?
Yeah, a great question. Yeah, so Enis, there are two things there. Why is mascale so user dependent? Because some people absolutely love it and they're reporting great outcomes, and they say this works in my hands most of the time, not all the time, but most of the time, and other people are saying this has never worked for me. Why is that?
It's technique, I think, mainly. The important points to remember are, in putting the cement spacer in, you have to put a large amount of cement so you create a big volume for when your membrane forms. I think it works better with a nail rather than a plate. And I think when you come to your second stage, decorticating the bone and making the bone ends healthy, and then having a decent membrane which you can then sew over the top, I think increases your success rate. So I think it really starts from that first operation. I've found mascale that's been done as an aside at the end of the operation. Someone puts in cement and then hands it over to me to then manage. The membrane is often not of good quality, and the volume is quite small. So I think the key is really that first stage is quite critical.
Greg, any thoughts on mascale? It works in your hands, doesn't work in your hands?
The answer to both questions is yes. Yeah, I mean, it's totally technique dependent, and you have to think of other things as well, such as who the host is, right? So some patients are just not going to. Some patients aren't going to do very well with it. Some other ones who are younger and healthier and have really good tissue beds might do better. So I've had variable success with it. It seemed to be okay in my hands. But I think the people that are running into trouble probably most often are attempting to really push the limits of the bone defects that they are treating with this type of technique. And I don't think we've had it quite figured out. So I would love to spend some time with people who are filling 15-centimeter defects in a femur with a mascale technique, because I'd love to see them do that. And I'd love to see their clinical follow-up of that. But I think using the transport nails is just a sensational idea. I don't do that personally, but I have a partner here who does. using circular frames for transport are fine too, but patients generally absolutely despise those. So especially on the femur. But yeah, I do a fair bit of masque technique, but I can't say as to the fact that it's always super reliable the way some of the super fans will say.
Yeah, we've had some answers, questions from the Q&A about Ilizarov technique, which I guess a nail is Ilizarov technique. It's just not using a frame. Has the nail, particularly in the femur, has the nail completely wiped out the X-Fix or the Ilizarov frame?
Yeah, I mean, I think patients hate frames, and patients hate frames on the femur even more. I think the lengthening nail has really revolutionized that aspect. And certainly in the femur, I think that the place for a frame is diminishing.
Right. Right. Okay. The thing that another question has been asked is retaining bone fragments. So, Enis, I'll kick off with you, and then we can all have a little pop at it. I must say, I'm not one for lagging in. Let's say you've got your shaft here, and you've got two large cortical fragments, one on this side, one on this side. Both of them have virtually no soft tissue. And as part of your debridement, you would normally throw those in the bin. However, you could make that one click in there and that one click in there and put some mini fragment stuff together, or whatever you like, to lag them back in and reconstitute some kind of shaft of femur. This has been popularized by the Bristol group, but and other people say they do it, but they're not X-rays that you commonly see. And I was just wondering what the faculty's experience of that is. Culturally, we don't do it in our institution, but I'm open to hear everyone's take on it.
I'll jump on in. Yeah, I'm a big fan. I mean, I put my hands up and say, obviously I was trained in Bristol, they weren't doing it and I was there. And I say I've come that way because everything else I've tried hasn't really worked. I've got quite a few cases now of bone I've taken out, I've washed it, I've then tucked it back somewhere else. So I was thinking, well, if the neurosurgeons, they can keep their skulls, then I'm going to just keep a little bit of tibia. So I've just tucked it under, and then I've come back and I've fixed it anatomically and keyed it in a week later. And I'm not talking about tiny, tiny bits of bone, as Enis alluded to. It's sort of large, really structurally important cortical bone. And they are in terrible, terrible hosts, and it's all gone well.
Greg?
Yeah, so I've not bought into that myself. I think it's intriguing. I think the some of the stuff that is coming out of, for example, from Bristol, and I've spoken with Ms. Ward about this as well. I mean, it's compelling. It's just really hard for me to get over the cognitive dissonance that I have with all of the training where these pieces of bone are going into the bucket now. But it does make sense, right? I mean, if we are really doing a good job with debridement, then it shouldn't be a huge issue. What I have done, though, is I will say I will take large cortical fragments that I know are going to go in the bin eventually. And if I'm taking them out at the initial debridement, I might save them and actually sterilize them. We'll put them in a specimen cup, and we'll put them in the autoclave and sterilize them, and then hold them sterile until the definitive reconstruction. And then I can use them as puzzle pieces, so I can potentially improve my reduction quality. And then once I have the fixation placed, then I just take the pieces of bone out and I throw them away. So I just use them as templates almost for my reduction. But I haven't gotten to the point where I'm retaining cortical bone fragments. That being said, we do it all the time for large fragments of bone that have articular surface and that obviously don't have soft tissue attachment. In open distal femur fractures, we do that all the time. We retain those pieces. So by extension, we should be able to retain cortical fragments if the wounds are clean, right?
My main issue is the types of cases. I find that it doesn't seem to be as black and white as what is made out. They even seem to be in hundreds of pieces, in which case it's not possible. Or I don't know, I just haven't quite found the case mix to make it a compelling reason for myself. I have done it. So for example, if there's a large butterfly, which means if I remove it, I'm then looking at a 12 centimeter bone loss, Whereas if I retain it, then it's 3.5. Then I will keep the bone and plate it in place. But they've often got soft tissues attached to it. So I'm kind of not a full convert. I'm yet to see enough post-op x-rays for me to convince it actually is a reliable technique. People just don't seem to show those x-rays. So I'm not entirely sure yet whether it's true.
As with so much, yeah. Guys, it's bang on 90 minutes. I was going to hold it up there and just call it. I was going to give a very quick summary of just like some take-home message that I got from each of your talks. Is there anything else you guys from the faculty wanted just to highlight? I think we've done pretty well with the Q&A and answering stuff. Oh, distal femur replacement. Oh, we ought to cover that. Jane, can you hit me with distal femur replacement? Where is that in the osteoporotic like option box?
I think you have to have your surgeons there. So I don't do any arthroplasty, but obviously not every distal femur in the elderly is going to be suitable for fixation. So you have to have that option available within your unit. I think with different techniques, you can now push what you can fix. I think you have to be honest and say, well, was the knee a good knee in the first place? And I don't want you to walk away thinking that distal femurs are the answer, because when they go wrong, what is then the solution after that? We've all seen them get infected. We've all seen them break or loosen at the top. So it certainly in our unit wouldn't be our go-to, and we're probably using that maybe for second or third stage perhaps.
Greg, any of your what's North America doing? Is anyone publishing series of distal femur replacements for these things, or is it just too big a call?
Yeah, not really yet. But the questions that you're asking and that the participants are asking are very good ones. And in fact, we've had a couple of periprosthetic distal femur fractures above total knee arthroplasties that have gone bad relatively quickly. And it's really prompted a lot of thought about trying to figure out who would best benefit from a distal femur replacement at the beginning. And I couldn't agree with Ms. Ward more than the fact that distal femur replacement goes bad. There aren't a lot of good options, right? It's terrible. So I don't know. And I think the hard part is trying to figure out who would indicate. And I think that is a very, very blurry set of indications. So it also really does depend on the surgical resources that you have at your institution. I don't do arthroplasty either, but I've got 4 partners who are very facile with distal femur replacement, and they're very, very eager and willing to help for these. So if you have those resources, it's helpful.
Enis, do you want to finish with the mic on distal femur replacement, or is it not really?
Yeah. Well, I find that there's either the patients are too young and you really don't want to give them a distal femur replacement, or if you can find an arthroplasty surgeon in my unit that will do it, then they all say yes, but when it comes down to it, they say no, because they're open fractures, the risk of infection, and then it's just not convenient for them. And actually the actual kind of logistics seems to be harder to overcome. So I find they're either too young or they say no.